with this presentation. This is our team. We don't have any relevant disclosure. Images are from our own practice. We have not used deepfake or AI generated images. Objective is that in a resource limited setup like ours, peer learning from mistakes, misdiagnosis, and great calls is important for quality control. Secondly, most of our patients are poor in a resource limited setup. They deserve proper diagnosis on initial ultrasound examination. To emphasize these 2 points: peer learning from misses, misdiagnosis, and great calls. Secondly, patients deserve the best from our side. Now, this case was initially read as gallbladder mass. This is a case of gangrenous cholecystitis. The fluid collection at the fundus is pus, which has resulted in clumping together of clogged off membranes, which masquerades as mass. Surgical finding was concordant. Only the pus at fundus could be drained. Because of massive adhesion, whole of gallbladder could not be removed. We did do a follow-up on this case at 6 months, and on follow-up examination, the remnant gallbladder did not show any sign of GB neoplasm, but we don't have proper histopathology on this one. So this is a case of acute gangrenous cholecystitis. Because the clogged off membrane is clumped together, it was initially read as gallbladder mass. It was a nice learning curve for us. Now this is a very classic case of gallbladder mass at fundus. We can see intralesional flow, hematogenous mets to liver with multiple retroperitoneal nodes. Now a case like this deserves proper staging on initial ultrasound examination. This will be stage 4 gallbladder carcinoma, T4N2M1. Another case of gallbladder malignancy with biliopathy and retroperitoneal nodes. Now, this gallbladder mass has directly invaded upon liver and descending portion of the duodenum. What we want to focus is there is cholecystoduodenal fistula formation, which is secondary to gallbladder carcinoma, directly infiltrating upon duodenum. This will also be stage 4, T4N2MX gallbladder carcinoma. The cholecystoduodenal fistula is very beautifully appreciated on this image. Now, this is a case of biliopathy, which is due to hilar cholangiocarcinoma, bismuth correlate type 1, very beautifully seen, abrupt cutoff of common bile duct. We don't have histopathology on this one, but this is a very classic case. Now, there are multiple solid hyperechoic lesion in liver. These are 2 different patients. Multiple hyperechoic lesion in liver can have lots of differential diagnosis, can be primary hepatocellular carcinoma, hyperechoic mets, or hemangioma. But the point is, focus on the posterior acoustic enhancement. Homogeneously hyperechoic lesion with posterior enhancement is hemangioma. You can stop there, no need for further evaluation, because blood pool in hemangioma acts as fluid, which results in posterior enhancement. Necrotic HCC, necrotic malignancy, mucinous mets can also have posterior enhancement, but they won't be homogeneously hyperechoic on ultrasound. So read my lips. Homogeneously hyperechoic lesion with posterior enhancement, hemangioma, period. No need for further evaluation. Now this is a very classic case of bulky mucin-filled appendix with no features of periappendiceal inflammation. This onion skin-like lamellated appearance is that of intraluminal mucin. Bulky mucin-filled appendix is always mucin-containing appendiceal neoplasm. At our practice, we don't use the word appendiceal mucocele because primary appendiceal mucocele is very rare. A mucin-containing appendiceal neoplasm is most commonly low-grade appendiceal mucinous neoplasm, appendiceal lamen, but except for that, we can have appendiceal Hammond, high-grade appendiceal mucinous neoplasm, appendiceal adenocarcinoma mucinous type, goblet cell, and even appendiceal neuroendocrine tumor with adenocarcinomatous differentiation can produce mucin. So whenever we suspect mucinous appendiceal neoplasm, we have to be very meticulous with the wall, because intact wall is our friend. Rupture of appendiceal wall with extraluminal implant of mucin forming appendiceal neoplasm of results in pseudomyxoma peritoniae formation, which is a catastrophic thing. Secondly, these lesions, they may at times they may remain stable for